Hi, my name is Amisha Mehta, and I'm going to be talking with you today about the treatment of nausea and vomiting. So to start with, the objectives of this talk are to match the etiologies of nausea and vomiting to their respective anatomical sites involved in communication with the vomiting center, and then to select specific treatment options for nausea and vomiting with a mechanistic and patient-centered approach. So to start with the case, we have NV. She's a 54-year-old woman with a past medical history of hypertension, diabetes, and CAD who presents to the ED for a 3-day history of nausea, vomiting, and inability to tolerate PO. She notes feeling dizzy and lightheaded and had an episode of near syncope earlier today. This is many of our patients that present to the ED and sometimes end up on our service. In addition, she also says that she's had constipation for the last 5 days and can't really recall if she's been having any gas because she hasn't been paying any attention to that. She also says that her nausea and vomiting is making her feel so poorly that she's now having trouble relaxing because she's so worried about the next time an episode of vomiting will strike. And she turns to you and says, "Doctor, please do something to help my symptoms." So when talking about the treatment of vomiting, we have a very short period of time to talk about it, but I think we can develop a guide that will help us when we have these patients under our care that require the treatment of nausea and vomiting. And the slides that are coming up are adapted from a wonderful talk that I went to at SHM in 2018 at the National Conference, given by Dr. Mills of the UCSF Hospitalist Group. So when we think about nausea and vomiting, it all starts at the vomiting center, and that's the main problem that we have. Is the vomiting center here is represented by the 2 green dots in the middle, and that's in the medulla. And the vomiting center in the brain is what tells the whole detailed production of what to do when we need to get rid of our gastric contents, which we call vomiting. And the goal is, can we in any way prevent the vomiting center from being activated? And what I want us to go away with is not what I learned in my training, which is try one agent for emesis, and if that doesn't work, try another. And if that doesn't work, try another, and do a blanketed shoot from the hip type of approach, but actually do a mechanistic, patient-centered approach based on what their etiology is for their nausea and vomiting. Because the more effectively we can treat their symptoms, hopefully the sooner we can get them out of the hospital and back to their regular daily lives. So there are 4 primary mechanisms through which the vomiting center becomes activated. And the first, which is sometimes the most common that we think of when someone presents to the hospital, is a gut-related disorder. So that can be anything from mucosal damage, from METs or GI infection, from PUD or IBD. It can also be from gastric irritants like radiation or drugs, and it can also be from a stretch effect like obstruction, ileus, or gastroparesis. And so how do we prevent the signal from the gut going to the vomiting center that tells the body to induce an episode of emesis? So the primary receptor involved is serotonin. And so this would be our patient that we would actually want to give a serotonin antagonist to, and we often use Zofran. Additionally, we can add a prokinetic like metoclopramide, which is helpful not only because metoclopramide acts as a prokinetic, but it also acts as an antagonist toward the signal from the gut to the vomiting center. So it acts in both directions. And finally, if we're still having trouble, we can always consider sphincter modulators, such as Haldol. So when we have a patient with gut-associated nausea and vomiting, things to consider are Zofran, Reglan, and Haldol. Now moving on to a different mechanism. Here in the red triangles is the chemoreceptor trigger zone. This is also in the medulla in the area prostrema. And the interesting thing about the chemoreceptor trigger zone is it is outside the blood-brain barrier, which means that every substance we have in our blood comes in contact with the chemoreceptor trigger zone. So vomiting that's induced through this mechanism may come from drugs, opioids, chemotherapy, digoxin, just to name a few. Also bacterial toxins, and then our metabolic disorders that cause vomiting like uremia, hypercalcemia, and DKA. So these are a large proportion of patients that we admit to our inpatient services. And what's the best way to treat their nausea and vomiting? So your primary agent is going to be a dopamine antagonist. And a dopamine antagonist can include phenothiazines and Haldol. And phenothiazines include Phenergan and Compazine, which are our two other major medicines that we use in treating patients with nausea and vomiting. So what I want you guys to think about is if you have a patient with an etiology for nausea and vomiting that could be related to triggering the chemoreceptor trigger zone, your first agent to use would be a dopamine antagonist and not Zofran. Additionally, if you still need help, you can use the inhaled isopropyl alcohol. And we can get that easily by going by our nursing stations and picking up the small square alcohol swabs that they have and ripping up a few of them, opening them up, and giving it to your patient to sniff. And that's been proven to be effective for patients that have vomiting due to this mechanism. There are also histamine receptors involved in the signal between the chemoreceptor trigger zone and the vomiting center, and so blocking these histamine receptors with meclizine may also be helpful for your patient. And then lastly, not that we can give these inpatient, but just to keep in mind, the cannabinoids are where we get the effect of their antiemetic through this chemoreceptor trigger pathway. So an additional mechanism is that the gut does have some effect on the chemoreceptor trigger zone, and this is just to point out that you're probably going to be giving them serotonin antagonists in the form of Zofran to directly stop the effect to the vomiting center, but it also does stop some of the effect from the gut to the chemoreceptor trigger zone. The next mechanism is through the cortex, and the cortex can be stimulated to cause vomiting through various ways. One is nauseous stimuli like pain, smells, and taste. Additionally, you can have memories, fears, and anticipation, which leads to cortical stimuli. And then the more classic, what we think about, raised intracranial pressure and meningeal irritation. So the pathway from the cortex to the vomiting center is not as well understood, and so we have less medications to directly affect this, but the two medications that we typically use to try to stop the activation of the vomiting center through a cortical cause is corticosteroids and benzodiazepines. And that's why a lot of times when patients are receiving chemotherapy, a benzodiazepine is built into their chemotherapy orders, and the reason is to prevent the anticipatory nausea and vomiting that comes with receiving chemotherapy. And then the final system is the vestibular system, and this can be activated through motion sickness, tumors, or infections. And if you have a patient that has a vestibular system etiology for their nausea or vomiting, there are two receptors that are involved. The two receptors are histamine receptors and muscarinic receptors. And that's why our primary modes of treating these patients are through meclizine and scopolamine. We don't have very many choices within these two classes of drugs of what we can give the patient. But in addition, phenothiazines can also help nausea that's activated through the vestibular system. And the thing to remember here is Phenergan is much more effective than Compazine. Although you can use both, Phenergan will give you greater effect than the Compazine, so try the Phenergan first. So this is the end of all the mechanisms that we have that can contribute to a patient's nausea or vomiting. The thing that I want us to take away is that this is not an all-encompassing list of etiologies or mechanisms, but this is 4 of the major ones. And of course, there are exceptions to the rules, but that when we have an admission order set that comes with PRN, Zofran for everyone that might have nausea, to really think about what's the etiology of the nausea and is there a different way that we should be treating it to help the patient's symptoms resolve sooner and get them out of the hospital. And with that, thank you for your attention.